Greetings, everyone. This is Eric Glazer. Welcome to Bright Spots in Healthcare, produced by Shared Purpose Connect. If you've not already subscribed to this podcast, what are you waiting for? We have all kinds of incredible guests that you could tap into, sharing incredible insights and ideas tied to how you can make healthcare better for this country, for the world. Take a look at it. You could hear guests like Randy Ustra, the CEO of ProMedica, a 13-hospital health system and health plan in Ohio, or the former Secretary of Veterans Affairs, Dr. David Shulkin. I could go on and on about the incredible organizations that have blessed us with their presence on this show and provided us with great ideas. Again, the mission of this show is to take these bright spots and share them with all of you so you could bring them to your organization to challenge your thinking, potentially clone these ideas wherever you are around this country. So I encourage you to subscribe to Bright Spots in Healthcare. Tell your friends, tell your colleagues. This is a great resource for all of you. Trust me, it's not me talking, it's my guests talking. That's why you should be subscribing. Okay, today we have a really special episode. We're going to talk about the abolishment of patients' medical debt and why this is critical to the business of healthcare and the overall health and wellness of millions of Americans. The title of the episode is Stop the Hardship: Why Providers should abolish patients' debt. This promises to be a fascinating conversation that I believe will open your mind or change your thinking around medical debt overall. I trust you are going to enjoy it. We are really privileged to have two special guests to address this topic. First, Tammie Jackson, the Vice President of Go-to-Market Strategy and Sales at TransUnion. Tammie leads TransUnion Healthcare's go-to-market strategy and is a client-facing functions. TransUnion Healthcare Solutions, if you don't know, they leverage comprehensive data, accurate insights, and industry expertise to help hospitals and health systems and large medical groups engage patients early and ensure earned revenue gets paid and optimize their payment strategies overall. TransUnion Healthcare Solutions helps over 1,800 hospitals, over 500,000 physicians collectively recover over $1.2 billion annually in revenue. We also have, joining Tammie, Craig Antico. Did I get that right? He is the founder of RIP Medical Debt. Did I not get that right, Craig?
You did. It's perfect.
Okay, good. We practiced that right before the show because I'm not great with last names. Let me tell you about RIP Medical Debt. They are a national charity that has acquired and abolished over $2.5 billion in unpayable medical debt since 2014. Let me repeat that. Over $2.5 billion in unpayable medical debt. Craig understands the ins and outs of the debt collection industry because he was a financial industry leader in collections, debt buying, and outsourcing for 3 decades. His experience includes working for IBM, Johnson & Johnson, and performing outsourcing and data analytics and advisory services for several Fortune 100 companies. Purchasing medical debts to then abolish them is the core of RIP's work, and it didn't cross Craig's mind until a chance introduction and facilitated by his longtime partner in the debt collection industry and RIP co-founder, Jerry Ashton. Jerry had connected with a group of activists and wanted to cancel debt as a charitable good using donated funds. So although the concept of forgiving debt goes back to biblical times, no one has attempted to do it on a national scale. Realizing the depth and scope of medical debt's burden on already struggling Americans, Craig and Jerry has resolved to start a nonprofit to champion this cause. So really excited to have you both here. This is going to be a really interesting conversation for me personally. Why is the right business strategy to abolish debt? So let me start with you, Craig, and that question. Like, why is it the right business strategy for those listening?
Sure. A lot of times hospitals want to give charity care. It's their mission. They really want to help the patients that either can't pay or are in hardship. But they only identify maybe 40% to 50% of the people that qualify, because they also make them sign an application, and there might be other things involved, like not being able to have the language correct, or they didn't even know that they could get charity care. So there's a lot of things that are against the hospital, even though they care about it. So many of the people that can get this free care because they would qualify don't end up getting it. And hospitals only have about, well, let's see, the rule of thumb is they have one collector for each 8,000 accounts. So what they have to do is they have to use collection companies to try to collect the money that they're owed. They segment it with TransUnion data to make sure that the lowest income people don't get placed for collection if they can. But certain rules and regulations require them to try to collect on the accounts, even though the people can't pay. So what ends up happening is collection companies get, billions of dollars of debt to collect, and they segment the accounts. And they might not collect on the bottom half or even the bottom 2/3 because they know that they can't pay. But guess what happens? Those people still owe the money and they still get letters, or it goes on to their credit report. Now, it's a burden. They know they owe it, and it stops them from access to care. They don't go to the doctor or the hospital because they owe so much. They know the cost is so high that it stops them from even going into the system, which ends up costing so much more. So one of the reasons why debt abolishment is the right strategy is because people don't know that you're not going to collect. Because after a few years, the hospitals do not collect on the accounts, but the people still have it on their kitchen tables and they still worry about it. And we're trying to remove that stress and hardship of the debt that's still owed. Because even after all the self-pay, the people that owe the money, they don't have insurance, even after all those people that pay and all the insurance that pays, the balance after insurance plus the self-pay piece equals about 160 to $200 billion a year that hospitals can't collect and have to use agencies for. So that's why they should.
Okay, we're gonna get into how that all works and how you operate to do all of that. We're even going to talk about HBO in a moment and the HBO channel and a celebrity on that network. But before we do that, before we go down that road, I want to ask Tammie to explain to everyone what is TransUnion's role in healthcare and medical debt specifically.
Yeah, thank you. And just thank you for the opportunity to visit with you all here today. I think this is actually a really good story. I love stories like this that are maybe less obvious, right? And so TransUnion has a value that we really live by, and that is information for good. And I think this is just such a good use case that demonstrates that. And so we really, in this particular specific circumstance with RIP, we really help to support. We provide the information so that RIP is able to assess the level of need. And then we can also help provide the information that they need in order to contact those individuals should they not have accurate contact data. When people think about TransUnion or any of the other credit bureaus, they traditionally think about our credit repository, right? That just makes sense. And certainly with over 1,000 fields per credit report, there's certainly a lot of very rich indicators within that group of data that is indicative of financial insecurity or either other social risks. But then we also have a very robust public repository, and the bridge between those two, which is the delta of those individuals that do not credit transact. Really, the compilation of the two helps us to be able to connect to nearly 95% of the US population. So this is just one example of how we can help support the healthcare industry and why we're so excited to be a partner with RIP.
Thank you for that. So Craig, let's talk about how RIP medical debt works, because I think what you sort of stoked in your answer to the first question is like, that sounds all great, but how does that all play out, and how do you operationalize it? So give us the 101. You're on mute, Craig. Happens all the time. I do it all the time, so don't worry.
Sorry about that.
No, it's okay. Go ahead.
Okay, let's go back to when I was in business and bought debt for a living to make money. because as a nonprofit, I still have to buy the debt for what the market value is to another for-profit debt buyer. Why would I want to not give the hospital or the medical group what they would get if they sold this debt to a for-profit collection company, a debt buyer? So the way the debt buying business works, let's say you take $100 million of debt from a hospital. They want you to buy it. Now, we know that not all of it's going to qualify under the 3 criteria that we use, but let's just say we're looking at that $100 million and trying to decide how much should we pay for it. A for-profit company will do a lot of data analytics. They'll add data from TransUnion, which will help them understand the makeup of these individuals that owe the money, ability to pay, whether they have a propensity to pay, whether they have ability to pay or not. All these things, are they transient, things like that. And I will have to, as a debt buyer, come up with the value of that portfolio. And it really is this: how much am I going to collect over the next 5 to 10 years, minus the costs of my collections? So let's just say I think I'm going to collect 15% of that 100 million. So I'm going to collect $15 million over the next 5 to 10 years. As a rule of thumb, I'm only going to pay a third of that. I'll pay $5 million. So I offer the hospital $5 million for that portfolio. Now, that's because I have to pay the bank back for what I borrowed. I have to pay the collection agency, which costs about a third. And I have to give the profit to my investors. And then I'm left as a debt buyer with this residual amount that keeps coming in over the next 5 to 10 years. What we're trying to do, and what we are doing, is we're going to those debt buyers besides the hospitals. We're going to the debt buyers and saying to the debt buyers, we don't think that it's right for you to collect from the 3rd year to the 10th year on this particular group of people. They can't pay, and they will pay, but it'll be under hardship. Because a lot of people pay because they just get calls and calls and calls and finally pay, but they really couldn't afford to pay. Now they're subsidizing. They're not subsidizing, but they're deciding not to eat, put a prescription in, follow up with care, things like that. So one of the reasons why we do this is because we're removing the hardship from it. We're taking the bad debt off of the credit report because now RIP owns the debt. Now, the debt that we buy, we've paid below 1%. So we thought that we would collect, if we were a collector, maybe 2.5% to 3%. We've paid as much as 6% of the, so 6 million of that 100 million. And because we thought we would collect, about 15 to 18% over a period of time if we were a debt collector, debt buyer. So that's how we decide how much to pay. Now, what's interesting, only about 20% of the 5,800 hospitals sell their debt. So it's a pretty low percentage. Now they're realizing that they could sell to an entity that's never going to collect on their accounts. It makes them feel much more comfortable than selling it to a debt buyer. But of course, not all the people are going to qualify. Only about 60% of the portfolios qualify by our first income estimate. Are they making less than 2 times the poverty level, the federal poverty level? So now what's interesting about that, about 33% of our whole population makes 2 times the poverty level and less. But every portfolio we've ever gone to buy has 60-something% being 2 times the poverty level and below. So just think of that. That's the litmus test for most charity care at hospitals. Does the person make 2 times the federal poverty and less? And some are even more generous. So we buy the debt. Now, so if we buy the debt for 1%, let's say we buy the debt for what we call 80 basis points, 80% of 1%. We buy the debt for 80 basis points. We thought we'd collect maybe 2.5% if we were a debt buyer. Now, the costs for the data, the cost for the mailing and the postage, and all of our other costs that are involved in the program are about 20 basis points. So the cool thing is when a donor, and these are the people that fund this, donors, they give us a $10,000 check, they get to abolish $1 million of debt. So if a big donor gives it, we just got a $50 million donation, that is going to abolish $5 billion of debt because it only cost us all in 1%. So you're just adding 2 zeros to that 50 million, and that's 5 billion. So that's how we operate. That's how we do it. It's a very big return on a donor's investment because we're able to price it at a market price, and not as many people can pay that are in hardship. Does that give you?
That's amazing. That's absolutely amazing. It blows me away that so few hospitals do this. I mean, it just seems like an absolute no-brainer.
We just started buying debt from hospitals. We're about to close on our second hospital that's selling us about $300 million of debt. And the hospitals are coming to us in a very big clip because we waited until we got an OIG letter that said that this was a safe thing for hospitals to do and a safe thing for us to do, as opposed to just buying debt.
OIG for the audience?
Office of Inspector General for Health and Human Services. They're the ones that put in the regulatory, mostly for Medicare and Medicaid, but we wanted to make sure that it was okay for those areas. We weren't getting into what we call fraud and abuse and anti-kickback regulations. So.
Okay, let's shift gears for a second because I want to get into sort of let's get into some Hollywood stuff here, right? So how did the HBO series Last Week Tonight with John Oliver affect your business, affect RPI Medical Debt specifically?
Well, RIP was not a household name before that. As a matter of fact, Jerry and I went into poverty doing this. So we knew how to do all the mechanics of this, and we had all the relationships, but we knew nothing about raising money. So I think we raised about $50,000 in the first 2.5 years. We were terrible. Now, along comes HBO. Now, we're going to build a statue for John Oliver because he's probably the main reason why we have been so successful. I have to say, over 15 million, I think, people have watched the segment that RIP was in. It's quite phenomenal. We didn't even know if we were going to be mentioned in the segment.
Well, wait a minute, back up. How did that even happen? You skipped like
I did skip. I was going to come back, but I'll get to it now. Let me go right to it. In the early stages of RIP, Jerry Ashton, my co-founder, and Robert Goff, our founding board member, wrote a book called The Patient, the Doctor, and the Bill Collector. So it's like exactly what we were. We were helping the patient. The doctor was really Robert Goff because he ran hospital administration, and Jerry, the collector, one of the best collectors I've ever met. So they wrote this book. It turns out a week before HBO, lawyers started having a question about what John Oliver was doing about the debt and collection business and the debt buying industry. He was doing a big expose on those two industries.
Okay, so the producers of the show and John Oliver, if he's the EPM as he is, they've already decided to do a segment in this genre initially. Yeah,
what they did was, I don't know if you've seen John Oliver. He's so crazy and funny because that's his main goal. His main goal is to poke fun at something that's really upsetting the world. And credit and collection has always upset the world. And debt buying doesn't have that much better a relationship with the people either. But what he does, he even looked at, say, churches, said, are there really any guidelines to what a church is? So he started his own church, and it was called Our Lady of the Perpetual Exemption. So he started the church. He was mocking that I'm the Church of the Hat or something, and they got an exemption. So he wanted to show how easy it was for a church to get exemption. So what he decided to do, he decided to start a debt buying company. He called it CARP for like the bottom feeding fish, the carp. and he started a nonprofit, and he was going to buy the debt and abolish it on stage, throw all the invoices up. And
Oh, so he was already going down this path.
he was going down it. He had already spent over $100,000 setting this up. He bought debt, about $15 million of medical debt. And then his lawyer said, can you really do that? Can you even take that data? This is HIPAA controlled data. You have to have, very tight systems. Are you going to be able to send letters out to these people? He's like, I guess. So he called up, the lawyers called up a person that Robert Goff gave the book to, one of his healthcare lawyers. That healthcare lawyer, when she got this call from HBO and kept, talking to them, well, you can't do that. You can't do that. You can't do that. It's like, what can we do? And she's reading through this book. She comes on chapter 10, which is got debt. Why not abolish it with RIP? So she came up with, she got an epiphany. I know what you have to do. You have to call RIP medical debt, because they abolished debt without having any tax implication for the debtor or the person that owes the money. So they called me and they said, Mr. Antico, we'd like to talk with you about such and such. I said, we shouldn't do this on the phone. I'll just come with my partner down to HBO headquarters on the West Side on Monday morning. You do that? Sure. So I go down there on Monday morning with Jerry, and we are laying out everything that they need to do. It just so happens, ironically, that the company that they got the 501c3 with, the nonprofit, I think they were, was our lawyer. Go figure.
Wow.
The lawyer that they had for, that was helping them was also known to us. So it was like a match made in heaven. So now the crazy thing, I didn't know what they were doing. I didn't know that they were putting a show on about collection industry executives and debt buyers. I had no idea. I just knew that they were buying this debt and abolishing it on their show. So we got to the point where I said, I think we can do everything you need, and we can do it within the next 3 weeks. They're like, what? So they said, all right, we're going to talk to our attorneys and get back to you. I said, well, we'll just stay here in the conference room until you talk to them. You'll do that? I said, yes, I'll do that. And well, we'll order sushi in. So we had sushi. In about an hour and a half, they came back and said, we're on. What else do you need? I said, well, I need like $50,000. So we added all this together, and they did their due diligence. And within 3 weeks, we had the show on HBO's Last Week Tonight with John Oliver. Now, one more caveat. We got our 501c3 a week before HBO called. If we did not get our, certificate of tax exemption, I don't think that would have ever happened either. So we were just, it's divine intervention. There's
Wow.
no.
And what did what were the results of that? So how much money did you raise as a byproduct of that exposure?
We raised about $250,000 over the next 3 or 4 days. Even though our website crashed, people were calling. They kept trying. They kept telling us that our website's down, but we had another crowdfunding place. They found that, and we're paying through that. So we probably could have raised another $50,000 for people that just decided, I've had enough of this.
Right.
But it was incredible, because ever since that, I think we raised that year, I think about 400,000. Then we raised 2.5 million the next year. Then we raised 5 million. Then we raised 10 million. And last year we raised almost 20 million plus the 50 million we got from one donor. So we raised 70 million last year. So it's quite amazing. And now we're up to $4 billion of debt abolished, or RIP is, for over 2.5 million people.
That's great.
So
since you mentioned it, what's your website?
It's
I don't think my audience is going to crash it, but just
No, ours is so tight now that no one's going to crash it. ripmedicaldebt.org. Rest in
Okay.
peace is how it was pretty morbid that I picked RIP. But once you started to get known, you can't change your name. So,
okay, let's, so I know, the way, medical debt and abolishment has always existed, but it is evolving, and the business of it is evolving. So I'm going to bring Tammie back in. How, Tammie, from your perspective, has the process of debt abolishment changed over the years?
I think that, when we consider, so now what, right? So now what can we do? What more can we do? And I think that, RIP and others in how we're trying to support them, we're trying to identify, are there other filters through which we can pass the population to better identify those that are in need. And so, that starts to shift over into an area of social determinant of health risk attributes. Okay, so whereas our first filter was financial instability or financial burden relative to somebody's income, now we're starting to look at what are some of those other factors? Because certainly, financial instability, financial stress, struggle will manifest itself in different ways, and it certainly can be a contributor to food insecurity, transportation instability, housing instability, so forth and so on. That's really how it is evolving. We're starting to layer in some of the, start to consider how we can do that. TransUnion has the capability to do that. So again, I spoke earlier about some of the attributes that will manifest themselves within a credit report. But then we also have a partnership with Socially Determined. And Eric, I think you had said before, you knew of that organization. ProMedica is actually a partner with Socially Determined as well. And what they are able to do is add analytics and technology so that we can assess risk scores and be able to not only discern, where the opportunities are within the community, but then from the provider side at an individual level, we can very carefully and strategically identify who those individuals are and the drivers behind the risk that we're finding.
Yeah, I mean, I think that bleeds into the next question I had planned, and I just don't know. Is there more detail around how you could quantify increased social determinants risks, and thus the medical debt risks, and how this all manifests itself? And then, with folks listening to this episode, how would you advise them, to leverage this approach?
Yes. So So you can quantify it, right? And so there are definitely within the credit report, there are attributes, and in the public repository, there are attributes that point to instability. For example, the number of people in a household, whether or not there's been a death in the family, your marital status, all of that stuff might be indicative of social isolation. Whether, if you've had a number of different address changes within a certain period of time, if you're behind on a mortgage or something like that, those kind of things can point to housing instability. And then, information about a vehicle or something like that can point to transportation instability. And so you can certainly quantify it. What the analytics and the algorithms that are housed within our technology partner with Socially Determined help us do is to kind of help lay on top of that. Okay, so relative, if it is food insecurity, relative to the resources that are available within a certain community, what is their risk relative to that? So it starts to layer in all of those different elements. And so, and if you think about, how does it manifest itself? The homeless population utilizes emergency departments and inpatient utilization 3 to 4 times more than others. Then when you look at, say, housing, and this is based on a Journal of General Internal Medicine, by implementing state housing interventions, they've helped reduce readmissions by 22 to 40%. So just by isolating, by delivering that kind of an intervention, it has that kind of an impact. More than 11% of households experienced food insecurity for over a year. And on average, adults who are food insecure have healthcare expenses that are more than $1,800 higher than those that do not. And when you think about even transportation, 10 to 51% of patients state that transportation is a barrier to healthcare access. And 3.6 million individuals each year are not able to obtain medical care because of transportation challenges. And for our older Americans, our older adults, it's an even more critical problem. And the last question you asked me was around what would I tell providers? I think, at a time when reduced cost and improving outcomes is really imperative to operational sustainability, really having, accurate individual and community level social determinants of health information can help round out an organization's population and community health strategies. We spend, $3.6 trillion on healthcare, and 80% of that spend is heavily influenced by factors other than clinical care, and that all of that research is well known. But really, when you're looking at aggregated data to help build your strategies, you can help to discern, do I have the right resources, whether that's physicians or access to other things in order to take care of this community? Do I have the right community partners that I can engage this community? When you look at it from an individual level, you have to understand not only that they're food insecure, but why. Is it income? Is it education? Is it access? And that's what we can help to do, is lay those pieces on top. So I think my message would be, it's not only good for the communities, good for your mission, but it's also the right thing to do from a business perspective as well.
And Craig, what are some of the additional, ancillary business benefits for hospitals? I think Tammie nicely laid out, why it's good for hospitals to be looking at this, because it does have a sort of a preventative, proactive kind of benefit to it. But what are some other business benefits, or just overall benefits? I don't want to call them business benefits per se.
Sure.
So
I mean,
folks to look into this.
When you look at a hospital's community benefit, they've got to show not only the government that they give to the community. There's three components of giving to a community. One is their charity care, and another one is their in-kind, meaning do they put on clinics and things like that. And then there's other things like education of mostly, medical education for doctors and nurses and others. Hospitals, nonprofits get about $60 to $70 billion a year in benefit, state, local, and federal tax breaks or benefits. And they've got to at least give that much in good. That's at least the way we look at it. And they give close to that. I wish they gave a little more to the charity care element, but I told you what the problems are with that. The ancillary benefits of what we do is, through TransUnion, we can let them know, we call it presumptive charity care, we can let them know which people really would qualify under their financial assistance policy. So an ancillary benefit of abolishing debt is, we'd rather you as a hospital give someone charity care than sell it to us or donate the debt to us, because that's actually right to charity care. It's right to their 990H, which is where they're showing how much they give as a cost, a percentage of costs. Right now, charity care is about 1.6% of their overall costs. Now, you can't say that that's how much they're giving, because you got to multiply that by maybe 5, 6, 7, because the bill was probably, 10, 12, 13% of expenses. Those are the ancillary benefits that I would look at. You're also looking at awareness for people in the community. So let's say we abolish that $300 million of debt for a hospital, and they send out, RIP sends out thousands and thousands and thousands of letters to the people in the community. Now, I don't think, and the OIG agrees, that they shouldn't publicize that RIP is helping them abolish their debt. But it's a prime opportunity to craft a communication strategy that's going to let the community know that charity care is available for them, that they care, that there's community charity care that's been funded. Now, that's an ancillary benefit, because RIP is like a federated awareness, I call it. The amount of earned media that you get when this debt is abolished is astonishing. It's the only reason why we've never had to go ask for money, because we have so much earned media, over 1,000 TV clips and mentions and videos of people having their debt abolished. Churches call us because they heard about us in a news flash or something. It's like, so that could help the hospitals just the same. It could help them give charity care to the people that need it. So those are two that I can think of off the top of my head.
Okay, let's, I know we're getting a little tight on time here, so let's try to kind of tie this up in a neat bow. Tammie, how can organizations gain a better understanding of the true drivers behind some of the most costly chronically ill within their population, and then be able to sort of target, I guess you can't, target or focus on, how that may play into their balance sheet as it relates to risks of debt?
Let me try to answer that, and you can tell me if I answer it well enough. So how can they? I think that you do need to leverage some kind of outside data repository that can help supplement the information that you have inherently on your own attributed populations, or even your own employees. And that's something we haven't talked about. When you are crafting benefit plans for your employees, understanding what the inherent risks are in the communities in which they live is a way to help do that, so that your employees have the resources they need. But I think you have to, and you're right, what they do have inherently on their own patients, on their own attributed population or employees is very important, right? So that diagnosis is important, but I need to know, of my diabetics, how many of them are food insecure, how many of them have transportation risk. And I don't believe, generally speaking, that most organizations would have that information themselves. So they would have to seek that information somewhere else. Did that answer your question? I'm not sure it does.
Yeah, I think so. And I think it's a good segue to maybe our last question. That would be for Craig. How are you identifying where in a country or a state or a county that you should be focusing on as far as individuals with debt and who are struggling, and maybe these same people that Tammie was just alluding to, and then how can providers with this information, how can they leverage this to help their overall operations? You're on mute.
Part of what RIP is going to use this $50 million donation that we just received is to target communities and piggyback on the network of people and social organizations, government, hospital, other healthcare, to help the whole community. Because we have to start deciding where to go. I mean, like, you might look first at a safety net hospital, like in Atlanta, for example, where it's predominantly very, very poor, and try to help those people. Like a lot of the banks, for example, will come in and do Community Reinvestment Act work in a community, but they forget that they need to actually help them first get stabilized with to help them with their debt, help them get out of their financial hole that they're in, and then bring in training and other things. We're going to be organizing around communities that have great needs. Before we used to go wherever the donor wanted us to go, and now we're more directing the donor that this is where we need you to put your money, as opposed to just this little county or this group of counties. The other thing is we are going to use this, or RIP is going to use the social determinants of health to understand where this need is higher. For example, we found that over $55 billion is given to friends and family for medical expenses and debt every year. Now, that's predominantly given to people that have a network, right, that are not socially isolated. We are designed to help the people that are socially isolated, that don't have Mary and neighbor and a crowdfunding campaign that doesn't get put on because they're spending 20-30% of their income on cancer debt. Like, that's not uncommon for someone to pay 20-30% of their gross income. Or a transplant. It's not unusual to be spending 30, 40, 50% of your income. So we have to go to places that we think have the biggest so-called bang for the buck and wellness for the buck. Like right now, what we're doing at RIP is we've had MIT, University of Chicago, UCLA, Stanford doing randomized controlled trials on first economic impact of medical debt forgiveness, and second on the wellness of debt forgiveness. How does it affect people's wellness? And those are things that TransUnion supports for us and the researchers. It's amazing the partnership that we have and what it can do. We raised over $1.5 million just for that research. They raised another $1.5 million, the researchers. So we don't know yet the best place or the best dollar to abolish, and we're learning every day, and the data is informing us, the research is giving us evidence, and that's the only thing you can do. You guess, and then you let the evidence and data direct you to where you need to go. And that's why data is so important, and being able to understand it. And that's why, TransUnion is a helpful partner. You look at socially determined, they're giving insights, not just the data. I wouldn't know what the heck to do with the data anyway. But that's what's happening, is we're getting better and better at using and getting insight from data. And the hospitals never really looked at their patients as customers. And they are one of the most important customers that any of these businesses could have. And it's about time that they start using the data that TransUnion has to identify them as customers, not just patients.
Great. That was a great way to end things. There's really, both of you, the work you're doing and your organizations are doing, I think is just incredibly noble. And it's just a great way of making the world a better place. Certainly a bright spot in my mind. I'll start with you, Tammie. How could folks find you if they wanted to reach out? Are you on LinkedIn?
I am on LinkedIn. I am. That's a good place to
So
reach.
it's Tammie Jackson. Don't make the same mistake I did, folks. It's spelled Tammie, Jackson as it sounds. And Craig, take yourself off mute. Craig, how could folks find you?
They could find me at ripmedicaldebt.org, or they could go on LinkedIn and send me a message there. I'm always quick with getting messages back to people.
Right. And that's Craig. I'm going to spell your last name for everyone. Antico, if you're just listening. Folks, thanks so much for listening. Again, please subscribe. If you like an episode that you happen to download and listen during your walk or your drive or whatever, please make sure you give it 5 stars and maybe even write in a comment. That definitely helps the show reach more folks. Our job is to share as many bright spots with as many people as we can. So you can help doing that by participating on your podcast app with the ratings and the comments. Thank you if you take the time to do that. Thank you in advance. This marks the end of the show. Craig, Tammie, thank you again. This